I'm really appreciative of the opportunity to come and spend a few minutes with you all today, because my goal is to rock your boat, to change the paradigm of how we look at injuries, how we see pain, how we look at adaptation. By way of explanation, that ankle sprain that John sustained, it took me 15 minutes to get him back out on the court. Now, not only did I manipulate the joint back into alignment, I also cleared the lateral stabilizers, the peroneal muscles to the ankle. And it's one thing to create mobility, it's another thing to create stability. And if you can't do both, you're pretty much predisposing people to future injuries. That's why once you sprain an ankle severely, it's easier to sprain. It leads to what's called a chronic ankle instability. And the medical literature indicates that that's a common denominator in patellar tendonitis and intertrochanteric bursitis or hip pain. So, Kevin Durant, ESPN writer Kurt Goldsberry, when asked in an interview, what has been your biggest takeaway from this series so far? Unfortunately, our understanding of load management and injury risk remains inadequate. Durant's Achilles injury represents a troubling new data point in the world of sports medicine. Even at the highest level, we still don't have a firm grasp on how, why, and when injuries occur. Notice his right calf in this video. See it pop? Now, he pulled that calf muscle 2 weeks prior to that injury. That injury could have been predicted. And they failed. That happens all the time in sports injuries. So how do we predict injuries? How do we prevent injuries? So there's a new law in the 21st century. It's to disrupt or be disrupted. This advanced muscle integration technique represents a disruptive technology. So our mission is to accelerate healing, maximize function, human performance. We predict and prevent injuries. That's what we do on a daily basis in our clinic. So it's sports chiropractic, it's a specialty. It's a precision neuroproprioceptive approach to evaluating, diagnosing, and predicting injuries, and thus preventing injuries and accelerating healing. A system that supports the best in sports medicine and sports chiropractic. The key to my success has been integrating the best of the disciplines. Good medical care, good physical therapy, rehabilitation, and good chiropractic care. Now, what I do has a foundation in chiropractic, but the bulk of what I do is not chiropractic. So, that last shot that Stockton made that put us into the playoffs against Chicago that year. Game 5 against Houston, Stockton set a hard pick on Charles Barkley, and Charles got ticked. So about 5 plays later, Barkley slammed Stockton to the floor and he landed on his butt, and it injured his low back. The next morning when he came to breakfast, he was antalgic. I said, "Stock, what's the matter?" He said, "Buhler, I can't stand up." He said, "I got pain shooting down my leg." That's a disc injury. I kind of got sick to my stomach because we're in the playoffs, we're tied for the Western Conference Championship. We got our main player who can't stand up because of an injury to his disc. Well, I worked on him for an hour and a half that day and an hour and a half the next day. By that second hour, he was still in trouble. And I'm saying, "Stock, this is as good as it's going to get right now." He says, "Buhler, you can do this." So I just continue to clear muscles. We'll talk about that in a little bit. And by the end of that third hour, he was standing straight. He had no pain. And that's the game he shot that final buzzer beater and took us into the playoffs against Chicago. Now, what that taught me was it's possible to reverse an acute injury like that in a short period of time. People say, "Well, you can't heal that fast." Well, you look at that ankle sprain that John sustained. How do you heal the tissue that fast? So if you look at the dynamics of an ankle sprain, most ankle sprains occur when they're full plantar flexed and inverted, right? In that process, you torque the talus. And as you torque the talus, you separate the fibula from the tibia, which puts stress on the interosseous membrane. Any muscle attached to that area becomes inhibited proprioceptively. It's how the body protects itself. So if you're loading a tissue that's lost its proprioceptive integrity, you're going to tear things. Now for Stockton, I treated him his whole career. He'd sprained ankles before, we would treat them. So the integrity of the muscle and the connective tissue was such that he could sustain that kind of inverted position without doing a lot of damage. So when I was in high school, a friend of mine ruptured his ACL. They cut him from here to here, replaced the cruciate, they casted him from here to his ankle. He was in a cast for 8 weeks. He never played sport again. Today they make 4 little incisions, they replace the cruciate, and you're up that day. They found that the sooner you get mobility, the better your recovery. So why should that be any different for a sprained ankle or any other acute injury? Once you set the joint back, reestablish the mechanoreceptors within the joint, you reactivate the proprioceptive mechanism of the lateral stabilizer muscles to where you challenge through those planes of motion and it's rock solid, strong, and no pain. Walking and running becomes therapeutic. Even though you do have some tissue damage, you're going to lay down any kind of scar tissue in a functional pattern rather than a dysfunctional pattern. Make sense? So the proof's in the pudding. If you can reestablish return to play criteria in a matter of minutes, why would you wait 6 weeks? They say, well, you can't heal tissue that fast. Really? So if what I did with the players at the Jazz were detrimental, Stockton would be a cripple today. As it turns out, he's 59 years old. He still plays basketball against Gonzaga basketball players and takes them to school. He's still not as quick as he used to be, but to be able to play at that level is pretty amazing. So the history of this model started with Dr. Alan Beardall in the 70s. I met him my first week in chiropractic college. He and his wife spoke at our for entering in class, and I had this deep impression I needed to get to know him. And so through my 4 years of chiropractic training, I spent a lot of time with Alan, and during that time he was actually developing this work. So I got a great education outside of the model or the standard training at chiropractic college. Alan expanded anatomy. We'll talk about that in a minute. So 41 years. In 2010 I went to the Olympics with 5 of my athletes. Each of these athletes were broken down 3 to 4 months prior to the trials. They were recovering from surgeries and injuries, kind of plateaued, in pain, and thinking about quitting. Tora Bright sustained 3 concussions 8 weeks out from the games. And when she came into they put her in a dark room for 2 weeks. And she came into my office 3 weeks post-injury. She couldn't stand on one leg without falling over. She was that unstable. We did some cranial work, special cranial work, and within 3 treatments, she was standing on one leg with eyes closed, completely stable. She went on to win a gold medal in the women's half pipe, which required impeccable balance. Ellie Oberwitz, speed skater. Travis Janer, speed skater. This is Shannon Barkey. She was recovering from ACL replacement surgery. And she's three months out from the Olympics. She's been rehabbing for 1.5 years, still in pain, ready to quit. We worked on her for about 8 weeks, got her balanced. She made the final place on the women's US team. She won a bronze medal. Steve Nyman, I started treating him at 18. He was a national junior champion. He's been to 3 Olympics. He's training for his 4th Olympics. He's 38 years old today. And he sustained 2 ACL ruptures, a PCL rupture, and a ruptured Achilles tendon. When you're skiing down a sheet of ice at 90 miles an hour, you tend to do some damage when you crash. What's unique about this is that he tore his Achilles tendon in November of 2011, and in February he was training again, and he won a World Cup that year. Now you compare that to Durant, you're going to find that he'll probably take a year, which is pretty much standard, to be able to recover, but he'll never play the game the same as he did. So this model represents a significant advancement in treatment of severe injuries. This was a graph of the motor output of Steve's vastus medialis upper division. The quadriceps aren't 4 muscles, they're actually 13 muscles that make up the quadricep complex. Each muscle division has its own nerve supply and its own function. So this was the motor output before I treated him. And in 7 minutes, that was a change. That's post-injury. That's a significant output because you're seeing he's able to sustain 10 pounds of force, but he can't hold it for more than a half a second without breaking. But as soon as we treated him, he can hold double the force and for a full 3 seconds without breaking. With that kind of motor output, the muscle's now ready to be rehabilitated. I worked with the Utah Jazz from 1979 to 2003. We had a great system in place. We had a trainer that embraced what I did. He pretty much controlled the player injuries. So when a player was hurt, the orthopedist would evaluate, rule out pathology, and then I would start treating the player. And it was a great run. This is the statistics. So we started collecting data in 1984, and these were the player missed game due to injury rates. This year, Mike Sheminsky came on board. Don Sparks, the original trainer, retired. We brought in Mike Sheminsky. He had no experience of what I could do, so he treated the player injuries medically. So I didn't see a lot of the players at that point. And then each year, as he recognized the power of what I do, he started referring more and more of the players to my office. And so the last year he was the trainer, we had 11 player missed game due to injury rate, which is unprecedented in the NBA. And then he went to Seattle, and we brought in a new trainer, Gary Briggs, who had no use for me. All the injuries were treated medically, standard of care. You can see what happened to the injury rates. So in 2003, when Stockton retired, I resigned because I was pretty much put out to pasture. Stone Sparks, Jeff Hornacek. This is a great example. When Jeff played for Phoenix, he had his 3rd knee surgery. They completely removed his meniscus. The surgeon told him that he would be lucky to play another 5 years because he had bone on bone. So he played for Phoenix for another year and a half, then they traded him to Philadelphia. He played with Philadelphia for a year and a half before they traded him to the Jazz. So he's well into that 5-year period. When he came to the Jazz, that's as far as he could bend his knee. So when he ran the court, he ran on his toes because he couldn't go heel to toe. He was on anti-inflammatories every day to deal with the pain. When I evaluated him, he had nothing from here down firing. So we started working on him to reactivate the muscles. After about 6 weeks, we had everything balanced. He could completely straighten his leg. He could run the court heel to toe. He got off all of his medications, and he played for us for 5 years. I talked to Jeff a couple of months ago. He still has his knees. He's still going strong. So what that taught me was even though you have bone on bone, and one of the stories that the orthopedist tells is that he had Jeff's x-rays on a view box. And one of his colleagues came in and saw the films on the view box. He said, boy, that looks like you're ready for a total knee replacement. And the orthopedist said, well, that's Jeff Hornacek's knees. So even though you have degeneration or pathology to the degree that would require so-called appropriate knee replacement, if your muscles are balanced, you can still function at a high level without pain. So I started working with BYU's basketball team 4 years ago. We had a hard time getting the players to buy in. The first year we had 6 players buy into the program. Not one of them missed a game because of an injury. The second year we had 10 players buy in. We had none of those players miss a game due to an injury. So last season we had all but 2 players buy in, and we had 84 players that missed games. 82 were due to the 2 players that didn't buy into what I did. They eventually ended up having injuries that required surgery. The rest of the players didn't miss a game due to injury. This season, we had 100% buy-in. We had 0 player miss game due to injury for the entire season. That's unprecedented in collegiate or any athletic endeavor. So the reason for that is at the preseason, we examine every player for neuroproprioceptive integrity of every muscle in the body. We test 540 muscles for integrity. And so that gives us a blueprint as to where they're unstable. If we know where they're unstable, we can pretty much predict where they're going to have injuries. And then the therapy that we deliver actually reactivates those muscles back into their normal neuroproprioceptive function. And then as they condition, they're conditioning 100% of their muscles. And that in and itself helps prevent injuries. And then we monitor them weekly. We find a problem, we solve it. We don't allow them to break down. So the key behind this model is based in proprioception. So injury and proprioception of the low back. Proprioceptive asymmetries were associated with injuries, and the factor most highly correlated with the history of low back injuries was the presence of spinal disorders. Impaired proprioception resulting from injury may degrade lumbar motor function, increasing workers' risk of re-injury. Restoring proprioception of the lumbar spine after injury should be a goal of treatment. So, Sherrington's law of reciprocal innovation, are you all familiar with that at all? Okay, Sherrington's law of reciprocal innovation says that when a muscle contracts, it sends inhibitory impulses to its antagonist muscle and cause it to release. That's how we move. Muscles turn on and off in a coordinated process. If a muscle is proprioceptively inhibited, it loses its ability to inhibit its antagonist. So the antagonist stays contracted through all planes of motion. So when you contract the quads, they inhibit the hamstrings. And then when you hit the mid-stance part of your gait, the hamstrings contract and inhibit the quads. But if the quadricep complex is inhibited, it loses ability to release the hamstrings. And that's why people have chronically tight hamstrings, why it's so difficult to reverse that process. So we have to be clear about what it is that's the source of the problem rather than looking at the symptom, because oftentimes the area of symptom is the area of adaptation from some other area of instability. So you're treating the area that's symptomatic, it never gets better. So this is another interesting. The peripheral mechanoreceptors are located in various locations throughout the body, including skin, joints, ligaments, tendons, fascia, bone, fat pads, and the enthesis, and muscle fibers. All those tissues can be the source of pain. So the role of the mechanoreceptors is that of transducer to convert mechanical energy into new action potential. So the most sensitive structures that produce pain, according to Daniel Cafetta, MD, are the periosteum and the ligaments. In a scale of pain sensitivity, periosteum ranks first, then ligaments, tendons, fascia, and finally muscle. Now, in this article, which was in 1993, articular joint cartilage contains no sensory nerve endings. That was the thought process at that time. Well, since then, they came up with a new form of staining, and they found that the articular surfaces are loaded with receptor sites. Ligament injury may cause crushing, severe burning pain, similar to a nerve root that's inflamed or irritated. That's why so many back surgeries fail, because they operate on the wrong thing. Because if you overstretch a ligament, anytime you load that ligament, you're going to get a burning, searing, referred pain down through the distribution of the sciatic nerve. So that's when they came up with prolotherapy. They found that if they inject the ligament that's overstretched with prolo, that it would actually tighten the ligament up, and you could reverse that burning, searing pain just like that. So there's so many things in the works that are helping us be more effective, but the key is defining what tissue is the source of pain. So all acceptance, after the acceptance of proprioceptive input, the message then is transferred to the central nervous system and is processed at one of the three levels: spinal level, lower brain, which is the brainstem, also the cerebellar level. Cerebellar level is the slowest reacting part of that whole reactive. The spinal reflexes are the most rapid. So the brainstem level is really critical in this model, and this goes into chiropractic at the foundation. The pons medulla, you've got the foramen magnum, C1, C2. If the C1 vertebra subluxates, which it can actually displace, it can put chronic stress against the medulla and the brainstem. This is a central control mechanism of the entire body. All the neural pathways originating here cross through this junction. So if the atlas side slips lateral, it's going to put pressure on the meninges and on the brainstem. That chronic stress starts to shut down the central nervous system, and that's manifested as a global weakening. The body's designed to survive and create stability, so it will do whatever it has to compensate, and I'll demonstrate that a little bit later. So this is a chart recording of the motor output in a straight arm test pre-toggle adjustment. So there's 19 or 18 pounds, 15 pounds, and 14 pounds, but they can't sustain it for more than a half a second without braking. Following a toggle adjustment, you can see the change in motor output. I mean, it's instantaneous. So that procedure is probably the single most powerful tool in the healing arts because of what it does for people's health. So I lecture twice a year at the University of Utah, one to their sports psychology department, one to their TAs in their biology department. And this summer I lectured, and at the end of my lecture I asked for a volunteer. So Dr. Nelson, who's head of the anatomy lab, invited one of his students up. She's from Italy. She was on the University of Utah ski team. And a year prior, she developed permanent paralysis on the right side of her body. She couldn't control a coffee cup. So she had to quit training, and she was pretty much devastated by that. So I toggled her atlas in front of the class, and I got a great release. She got off the table and started to cry because for the first time in a year she could feel her hand again. Okay, complete normal motor function with one adjustment. Yes? I've got 7 minutes left? Oh, okay, all right. So, wow, time flies. So, you get patients for an adjustment, and after they're adjusted, they're bright-eyed and bushy-tailed. And so, we have to draw a distinction between muscle weakness, muscle paralysis, and muscle inhibition. Muscle weakness is a conditioning issue. And oftentimes we condition ourselves into imbalances. Muscle paralysis is a neurological disease, neurological disorder, but the concept of muscle inhibition is uniquely different. The enthesis. So, this is the model. When a muscle is overloaded beyond its ability to handle a stress, one of two things happen. You either tear the muscle and or the central nervous system inhibits it to protect it, just like a circuit breaker. Now once that happens, the muscle still fires under passive range of motion, but if you stress it or load it, it will give way. If you keep stressing, you're going to get pain at the attachment sites. So what the body does with that is it figures out a way to adapt by simply shifting the joint angle slightly. Now you're using a different muscle to stabilize that. And if you're successful in adaptation, your pain goes away. The problem is the muscle you've adapted to has to work harder. So it becomes the next site of injury. So you go from one injury to adaptation, injury to adaptation, and before long there's nothing left to adapt to, and you end up with chronic pain. That's when you're diagnosed with bursitis, capsulitis, tendinitis. What I submit to you is it has nothing to do with inflammation. After 6 weeks post-injury, it's no longer about inflammation. So once that occurs, the body has to create stability. How does it do that? By tightening the muscles to create stability. I've had people who have areas of complete muscle tension. You can massage and stretch. You can increase range of motion, but if you increase range of motion without having stability, you're setting them up for an injury, because within 24 hours, the muscles are contracted again to stabilize. Is the term arthrogenic muscle inhibition familiar to anybody in here? Okay, so there's, nice. So arthrogenic muscle inhibition is a presynaptic ongoing reflex inhibition of muscular surrounding a joint after distension or damage to that joint. The extent to which therapeutic interventions affect AMI is unknown. Arthrogenic muscle inhibition is a natural response designed to protect the joint from further damage. Now, what they found is that anytime a joint is irritated, inflamed, or damaged in any way, any muscle that attached to the joint or cross over the joint becomes inhibited. It's protective in nature. So that's where chiropractic comes in. When you manipulate a joint back into motion, you're influencing the mechanoreceptors in that joint, reestablishing the integrity, so any muscle attached to the joint or cross over the joint becomes functional again. If you have an athlete who has a joint that's irritated, they're predisposed to injury. Now think about this. If this is true, which it's in the physical therapy literature as a problem with rehabilitation post-surgically, the multifidus muscles, the rotatory muscles, are intersegmental in the spine. They're not designed for strength. They're primary proprioceptive based muscles. They control the larger muscles of the spine. So if you have an irritated or fixated vertebra affecting the facets, it's going to inhibit the multifidus and the rotatories. And as soon as that happens, you lose the proprioceptive control of the major muscles of the spine, which means you're predisposed to injury, low back injuries. So the next thing is what we call enthesis-generated neuroproprioceptive muscle inhibition. Now, you've got the spindle cells that monitor tension. You've got the Golgi tendon apparatus in the tendon. So if you load that muscle tendon too rapidly, the Golgi tendon inhibits, right, to protect. But as soon as that load's removed, the system comes back online. But you've got a fail-safe where the muscle tendon attaches into the bone, and that attachment site is called the enthesis. And the enthesis is loaded with receptors that monitor tension. So if the integrity of that muscle tendon is exceeded, rather than tearing, those fibers trip. And once they trip, the muscle still fires under passive range of motion, but you stress it, it'll give way. That can be the source of pain. So what's the function of pain? To protect us. So when you have pain, it's one thing to say we have tendinitis, bursitis, capsulitis, but my question is, what are you trying to protect? So we can evaluate the integrity of the muscle simply by isolating that muscle through its plane of motion using muscle testing. Now, muscle testing has been bastardized and has a bad name. This is all found in the literature, and I won't go into that. There's acute pain and chronic pain. If 6 weeks post-injury, you're going to have localized pain. After 6 weeks, your body's forced to adapt. So oftentimes after 6 weeks post-injury, you may shift to another part of your body to adapt, and that becomes the site of pain. So Beardall discovered that there were divisions to muscles. This is the medial compartment of the knee. There's the vastus medialis, the sartorius. Well, when we started looking closely at the fascial planes at this specimen, we exposed the fascial planes. You can see that this is the upper division, middle division, lower division, and the oblique division of the vastus medialis. So we've got 4 heads to the vastus medialis, 4 heads to the vastus lateralis, 2 heads to the rectus femoris, and 2 heads to the vastus intermedius, plus the articularis genu. Articularis genu attached to the distal aspect of the femur in search of the bursa. So when you bend your knee, that bursa goes around the condyles. When you straighten, that bursa has no place to go. And so the articularis genu contracts to lift the bursa out from behind the kneecap. When that muscle fails, usually because somebody falls on their knees, you lose that ability. So when they go into a partial squat or go up a stair, they're going to get knee pain. So this is the tensor fasciae lata, the glute max, tensor fasciae lata. Notice, well, it's hard to see right here, but there's a little tendinous sheath right there. When we exposed it, you can see that there are 2 separate, distinct muscles to that tensor fasciae lata. So it allows us to be more precise in evaluating functional imbalances. This was an article that came out. Dr. Nelson sent me this 3 months ago. He said, you might find this interesting. They discovered a new muscle. It's called the tensor of the vastus intermedius. This is the superior division of the vastus lateralis that Dr. Beardall discovered 42 years ago. So early on in history, Gray's Anatomy actually had divisions. But as new editors came online, trying to simplify it for the students, they removed the divisions. There's a difference between break testing, which is used in physical therapy and neurology, from neuroproprioceptive testing. This is the standard. So when you're testing a muscle, there's a certain amount of stretch that takes place in the connective tissue. Once that stretch is removed, then the muscles can engage in a working capacity. That stretch response should take place over half a second. And then once that stretch is removed, then the muscles engage. This should take place in a half a second. This rate of rise should take place in a half a second. And once you meet threshold, which is different for everybody, once the muscle locks in, you maintain that force. That's the standard. This is an example of a functional muscle test and an aberrant muscle test. Notice the stretch response and rate of rise is identically the same for both. The difference is only 2 pounds before the system breaks. So muscle testing can become a very precise analytic tool for evaluating functionality. This is what's called ideomotor phenomenon. This is a person who used muscle testing. You manipulate, you apply faster and harder to produce a weak response, and slower and less hard to produce a weak or a strong response. This is a Olympic snowboarder that injured her hip. The glute max sacral division, she could only generate about 23 pounds of force, but she couldn't control it for more than a half a second. After I treated her, we went from average of 21 pounds to 71 pounds. That was in 7 minutes. And you show me anything that will increase motor output to that level in 5 minutes, and I'll buy into your program. Okay. So as you can see, we're dealing with a uniquely different approach. This is another situation. There's 22 pounds, 18, 21 pounds, and after treatment, again, significant change in motor output. So inversion sprain, these are the muscles that are related to an inversion ankle sprain. So in order to treat, This person came in on crutches. They walked out carrying their crutches, pain-free. So this is the proteus longus cuneiform division. There are reflex points. There are 8 reflex points that have to be stimulated. 10, okay. There's a vascular point, a lymphatic point. We have to stimulate the attachment sites. And then there's 2 organ gland reflexes, 3 vertebrae in the spine that have to be adjusted in a very specific way, and an acupuncture point. This forms a circuit. So if the organ, like the bladder or the small intestine, becomes stressed, this muscle can become hypertonic, which makes it easier to sprain. So by stimulating all these reflexes, you can normalize the integrity of that muscle. Patellar tendonitis. Study in the NBA indicated that a common denominator for patellar tendonitis or jumper's knee was a restriction through internal hip rotation. They found that an interesting finding, but they didn't know what to do with it. So anyway, this was a study that they did, patellar tendonitis, axial skeletal problems. Just had more time to go through this. These are all the muscles related to patellar tendonitis, jumper's knee. All these muscles relate to internal rotation. So if you're restricted through internal rotation, these muscles are inhibited because the body will not allow you to go in a position that it can't stabilize. And then you've got all of the quads, muscles that make up the quadriceps, that have to be considered as well. And once you do that, we've increased vertical jump by 7 inches in a collegiate basketball player in an hour and a half of treatment, simply by reactivating these muscles. So, I need a guinea pig. Go. No, you. Yeah. You with the kind face. What was that?
How are you?
Good. You?
Good.
On your back.
I'm back.
Okay, so the first thing I want to do is just check his overall neurological function. Okay, I need that towel roll out. Okay, so arms straight. Okay, now I'm going to pull and you resist. Pull tight. Pull it. Okay, again, pull tight. Pull it. Okay, now he appears to be fairly strong, but he's lifting his shoulder up to his ear. So why would he do that? Because he's trying to recruit, right? So he's masking something. Now, if I'm testing, thank you. If I'm testing something that, again, a lot of chiropractors, a lot of physical therapists do muscle testing, they're going to miss a pretty important relationship. Now, if I drop his shoulder square to the table and bring his arm across, drop it down and lock right there. So lock your elbow. That's it. Now, hold it right here. Feels awkward, doesn't it?
Somewhat, yeah.
Okay. It's awkward because his central nervous system recognizes he's not stable. Pull tight. Keep your shoulder down. Bring your arm across. Right there, okay? Pull tight. See, I can pull him down with one finger. Now put your thumb and little finger together. Just like this. Nope. Yep. Nope. Yep. Okay.
Sorry.
Now hold tight. Pull tight. Okay. He's not that bad, but he's sweating right now. Pull tight. Okay. Now shoulder down, elbow straight and locked. That's it. Pull tight. Pull. Now push out against me. Push tight. Push. No, out. Push tight. Push tight. Push. Okay. Put it down. Push tight. Okay. Now push up. Push tight. Okay. Push tight. You're a lousy subject, but we'll salvage you, okay? So let me have you lay on your stomach. Okay, now with your legs stiff, I want to lift your right leg off the table as high as you can go. Down, and the left one. Okay, now see how restricted he is through hip extension? Normal is 35 degrees, and he's about what, 15? Would you agree? Okay. This is an example where the body will not allow you to go into a position it can't stabilize. So the reason he's losing hip extension is because these powerful glute max muscles are not engaging. So bend your knee for me, hold your leg up, Hold it up, 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 up. That's it, and push tight. Up, push tight. So he can't control that. Bring it up and across, hold tight. So we've got the iliac division and the sacral division of the glute max muscle. So I'm going to treat this muscle to show you pre and post change. Okay. So I'm going to work on the attachments into the sacrum, and then I'm going to stimulate the vascular point. Now, sore right here?
No.
Pardon?
No.
How about right there?
A little bit, yeah.
Okay. So there are thousands of reflex points on the outside of the body that reflect internal function. So by stimulating these reflex points, you reinitialize those back into the central nervous system. How many times have you got up in the morning and let's say you had elbow pain and you don't remember hurting your elbow, but it hurts like heck? Mm-hmm. That may be an acupuncture point to a muscle in the opposite knee that you stressed the day before working out. So you can go to the doctor, he tells you you got a little bit of tennis elbow condylitis, and gives you a script for an inflammatory, or might inject it with cortisone. That feels good temporarily, but it comes back because you're treating the wrong thing. Because once you reactivate those reflex points, the elbow pain is completely gone. So from a training standpoint, understanding that there are divisions to muscles allows you to look at the body from a more precise level, knowing that the body will not allow you to go into a position that it can't stabilize. Instead of working with somebody to strengthen them through those planes, you've got to take a look at why is the body trying to avoid that position. And Dr. Ryan Osborne is a chiropractic physician here in Austin that does this work. And the key is to work as in tandem. And then you guys get to have a better outcome with your athletes. They're all sore, aren't they? Mm-hmm. Yeah. Now people come in, they'll be struggling with sacroiliac pain through this area. Okay. This is a lymphatic point, and then it attaches along that femur. Now, how many of you have clients that deal with IT band syndrome? It's tough to deal with, right? IT band syndrome occurs when the glute max muscles and the tensor fasciae lata muscles fail. Because the glute max muscle not only attaches the femur, it also goes 2/3 of the way down the posterior margin of the IT band. It's the posterior anchor to that band. And so anytime a muscle inhibits and you use it, you get pain along the attachments. So when you have pain in an area, you've got to say, okay, what muscle attaches to that area? And that tells you what muscle is inhibited. Make sense? Okay. Is this the craziest thing you've seen all day? Huh? Now this is an unusual procedure, okay? But I'm not sure exactly why it works. I just know it stood the test of time at the elite level. This arthrogenic muscle inhibition information, I was exposed to that studying the literature about 8 years ago. It opened up a new world of understanding for why a lot of these things work. But these reflexes, I'm not sure. I think as time goes on, as we learn more about neurology, motor physiology, it'll start to make sense to us. Right now, I don't think we're there yet. So the construct of how we explain why this works may be completely off. But I do know that this is an inspired work. It took years of trial and error working with elite athletes to come to these relationships. Okay, take a deep breath in and blow it out. Deep breath in and blow it out. Deep breath and blow it out. Okay, lay on your back. Okay, now, Bring your leg up, arm up, lock it, and pull tight. Pull tight, pull tight. Okay, put it down. Leg down. So I'm working on the organ reflex centers for this muscle. Now we stimulate these points until they pulsate together, and it's not an arterial pulse, it's an energy pulse. Initially there's no pulse at all, and then they start pulsing at different rates, and then they start to synchronize. And initially there's pain at these points, and then as they synchronize, that pain dissipates. Did you notice that? The intensity of the pain dissipates? Yeah. Okay, arm above your head. Yeah, like this. Now the acupuncture point, nope. Acupuncture point just happens to be in the armpit.
Ooh. Oh.
You want to see a grown man cry? Okay, on your stomach. Okay, bend the knee for me. Hold your leg up and push tight. Push tight. Again, push tight. Push it. Good. Would you say that's a change? Okay. Now I want you to lift your left leg off the table. Kick it up as high as you can go. So how much stretching would you have to do to get that kind of change? See? So you reactivate those proprioceptive mechanisms, things just start to fire more efficiently. And, okay, sit up. Okay. Go thy way and sin no more, my son. Okay.
Hey, Joe. You said it.
Yeah. So I wished I had time to go through a full exam to show you how precise it is, but time flies when you're having fun. But anyway, thank you for this opportunity, and I hope that I've shifted your paradigm a bit to where you look at things a little bit differently. Anyway, good luck.